Morning. Morning. Just checking a few things. Looks like everything's good. Welcome back. It's Monday again, and yeah, busy week last week. Busy couple of weeks actually. Went to the anatomy labs on Wednesday, just gone. And Tristan was there, which was good. So good to see him again. And just trying to think who else was there from Learn Anatomy. I think we've had a couple of people join us now after those trips. So a chap called Kevin and Alice and Anna. So we should have a few new people on Learn Anatomy Online as well. Morning, Steph. Good to see you in. Yeah, so and then loads of stuff with the diploma as well. So doing us, this was really good. So a sonography course after the anatomy day, which is always really useful because to do scanning, you need to be pretty good at anatomy. So yeah, it was. So that was good. A couple of new people embarking on a sonography career. So that's always good to see. Yeah, and then so today we're going to be looking at the ligaments of the lumbar region. I've changed it to lumbar region rather than lumbar spine because it depends on how much time we've got. We may be able to get to the inguinal ligament, and we've covered it a little bit, but not in any great depth. So yeah, we're going to have a look at the layers of the kind of inguinal region in a bit more detail. So that's the plan for today, if that's okay with everyone. Morning, Tris. Good to see you on here again. Just saying about how good Wednesday was. So and seeing you, obviously. Oh, let's just switch that one to there. Bear with me a sec. We'll just go back through all these. Sorry. There you go. There's a brief preview backwards of what we're going to cover. So yeah, so we're having a look at so breaking down the spinal column. We've had a look at the bones and joints of the lumbar spine. We did that last week, and now we're starting to add on the kind of passive structures, those connective tissue layers. So we've got yeah, if you've not seen this before, I think I might have mentioned it, but different areas of the spine are given different bits of shorthand, and it depends on what profession you have as well. So I first saw LX together when when I was working at the university, and I was working with physios, and I was like, what the heck is LX? And they said, oh, that's lumbar spine. And I in osteo, we learned the shorthand as LSP. So yeah, it's different people, different professions have different shorthands, but that's what LX means. It's lumbar spine, and then obviously TX thoracic spine, and then CX cervical spine. So yeah, if you're not sure, I've not heard that before, then that's what that is. And then I wanted to start with this. So this is a typical kind of the wording on an MRI report. And one of the reasons I've got this up here is because after this session today and the previous session that we did last week, looking at the bony landmarks, you should be able to make a bit more sense out of what this is saying. And if a patient or a client comes up to you and has an MRI report and they're not really sure what it means, then you'll be able to recognize some of the things that the report is talking about. What they tend to do now, which is really good, I've seen it on a couple of reports, is have the kind of medical version and then a layperson's version written afterwards. And so that's really good. Good to see that kind of thing. So if we have a look at here then, so we've got T12L1, no central spinal canal or neural foraminal stenosis. 1L2, no central spinal canal stenosis and no neural foraminal stenosis. L2, L3, minimal disc bulge, mild facet arthropathy. no central spinal canal stenosis, and no neural foraminal stenosis. L34, trace retrolisthesis, minimal disc bulge, mild facet arthropathy, no central spinal canal stenosis, and there is a mild inferior foraminal narrowing bilaterally. Okay? And then L4, L5, 1.5 millimeter circumferential disc bulge, mild facet arthropathy, no central spinal canal stenosis. Okay, so that's the wording on this report. I'm going to leave that there. Do what we've got to do on the ligaments and stuff, and then revisit it and see whether some things that maybe you hadn't heard before make a little bit more sense. So well, hopefully we'll see after this. Just something else as well to do with the lumbar spine. Just move me out of the way up here. So this was an interesting study that was done a little while ago. When was it? Yeah, 2017. So what's that? 7 years ago now. And what they did was they looked at age-specific prevalence estimates of degenerative spine imaging findings in asymptomatic patients. So these figures are for people who had no pain. And these were the kind of things, again, that you would see on an MRI report, because what the person doing the report writes is what the image shows them. It doesn't have any bearing on any clinical assessment. Okay, they literally just look at the picture and then they write down what they see. Okay, so it may or may not correlate with clinical findings. And in this particular case, there were no clinical findings because the people scanned were asymptomatic. So what we could say is that these are normal findings because the people didn't have any kind of symptoms. So if we have a look here, we've got the age of patients across the top here, so from 20 through to 80. And then down the side here, we've got all the different kind of things that you might see on an MRI report, and the kind of things that they would highlight. So we've got disc degeneration, disc signal loss, disc height loss, a disc bulge, disc protrusion, annular fissure, facet degeneration, and spondylolisthesis. Okay, so what we'll do is we'll go through some of these when we look at the pathology of the region in a bit more detail. So we'll do it bit by bit. So we'll do some kind of bony pathology next week, bring in some of the connective tissue as well, and then we'll start looking at some of the other structures like herniations and things like that. So so that you'll get an understanding of what each of these things are. So we've got at the age of 20, disc degeneration was found in 37% of asymptomatic 20-year-olds. Okay, so well over a third of 20-year-olds who have no pain have disc degeneration. Okay, so in this particular study. And then signal loss, so that's usually where there's some kind of change to the disc integrity. We've got 17%. Disc height loss, so obviously reduction in height, 24%. A disc bulge in 30%. Okay, so when somebody comes to you with an MRI report and it shows disc bulges at multiple levels, they start to get a bit worried about it because if you Google that kind of thing, then you or even if you don't, you just imagine it. You kind of imagine this massive disc bulge pushing out onto the spinal cord, and you're going to have all sorts of horrendous neurological symptoms. So I think it's really important to show people that actually those findings, I mean, even if you're 20, a third of people pretty much have a disc bulge but have no symptoms whatsoever. We are going to do a whole series on what is a bulge, what is a protrusion, so that you can understand the differences between the two. And there's another term as well, sequestration. So we'll have a look at that as well. And so just to give you a bit better idea of what these things are. But yeah, so if you've got a 50-year-old coming in with an MRI scan that says you've got a disc bulge, they are very likely to have one anyway. And it may not be linked to the reason why they have back pain. Okay, and that's the thing. So sometimes it can be, but 60% of 50-year-olds have disc bulges without any symptoms. Okay, so this was a really good study that was done. So it's a systematic literature review of imaging findings, spinal degeneration in asymptomatic populations. So that's the reference there if you want to go and have a look at that paper. Cool. So before we go any further, then these are some key words that you need to know. So some of these were from last week, and they'll be really useful for today as well, as we start to add on the connective tissue and the passive structures. Okay, so what I mean by passive structures is they don't contract. Okay, so they usually have a stability or a kind of absorption type role, and yeah, they're not like muscles where they contract. So that's what I mean by that. So keywords then, we've got lamina, and we looked at this last week and where the lamina is on the vertebra. And I'll go over that again as we see the images again. Lamina is a plate or a thin sheet of material. So if you think about a laminate floor, yeah, so we've got these thin sheets of material. That's basically what we've got at the kind of back curve of the vertebra. And we covered this last week where the lamina is. And there are basically like sheets of or layers of bone. Okay, so that's what where that comes from. Transverse means across, or so where last week we were looking at the transverse processes. So those are the sticky out bits of the spine. Pedicle means a little foot. So if you think about pedicure, okay, then that's where pedicle comes from. Facet means little face, and it's like a very smooth surface. And remember, we were talking about facet joints, and their kind of true name, if you like, is a zygapophyseal joint. It's a bit of a mouthful, so we tend to call them facet joints. Okay, but they're very smooth, and you'll have a concave surface and a convex surface, so they kind of fit together and glide across each other. They're surrounded by a synovial capsule, which has then got synovial fluid in it to help maintain the lubrication in the joint. Okay. Superior means above, so you can have a superior facet, so a facet that is above. Inferior means below, and that is a below facet. And then articular means a joint. So where something joins something else, that is an articulation. And you might say that this articulates with this, so it joins them together. So like an articulated lorry. Okay, so that this one which is joined. And then a foramen is an opening. Okay, so we've seen foramen a few times, especially around the pelvis. We were looking at the obturator foramen near the ischial tuberosities, where the obturator vessels go through and the obturator muscles attached to. And in the spine, we were looking at it last week. There was a neural foramen, and that's where the nerves pass through. Okay, so they come through that opening. It's like in the spine, it's a bit like an archway or an oval shape. So those are key terms for today, and from kind of a bit of a recap from last week as well. This is this is from a while ago, so 2001, and this is the prevalence of kind of different pathologies relating to lower back pain, and things that you should be worried about, things that are systemic, things that are pathological, and some that are more mechanical. Okay, so this is the paper, so you can have a read of it if you want to. So mechanical lower back pain or leg pain is accounts for 97% of the things that you see. Okay, or will see if you do that kind of job. Non-mechanical spinal conditions are usually around about 1%, and then visceral diseases are 2%. You know, well, that's a bit weird. How can a visceral disease be counted in with lower back pain? And it's because it refers to the back. So if you have a problem with the pelvic organs, with prostatitis, endometriosis, you can often experience back pain. And it just presents differently to these mechanical type presentations. Usually with a mechanical one, if you have injured something, so let's have a look. So we've got a lumbar strain or sprain, idiopathic, so that means we don't really know what's caused the pain. No pathoanatomic confirmation, so they've had a scan and there's nothing on the scan. Okay, that accounts for 70% of lower back pain. Again, this is back in 2001, so it'd be interesting to see if the study's been done again. But what they're saying is that 70% of lower back pain coming in is because if you've strained something, then if you rest and sit down or adopt a certain position, usually it then doesn't hurt because you're not then straining it even more. So it's if it's something like prostatitis where you've got inflammation of the prostate, it doesn't matter what position you get into, it's not going to change that inflammation and it's not going to change that sensation because it's not mechanical. Yeah. So if you can move around and it feels a bit better, then that's a really good sign. It's more likely to be this mechanical issue. Whereas if it's one of these, it doesn't really change. Okay. So but visceral disease causing lower back pain is very rare. Okay, so only 2% of in this particular study. And then non-mechanical spinal conditions, so neoplasia, so you've got like new growth, basically that means, so usually cancerous tumours. Multiple myelomas, metastatic carcinoma, so again a cancer that's spread to the spine, spinal cord tumours, retroperitoneal tumours, so we're talking about usually like cancerous tissue. And these kind of things, again, they're quite rare, about 1%. So the majority of people you see are likely to be something like this, okay? Which is, like, thank God, because that's stuff that we either can signpost people to get treatment, or we can help ourselves, depending on what your analysis is. So that, again, that's something, or that this table is quite useful to understand. And if there are some things on here that you've never heard before, we're going to cover some of these when we look at the pathology section, but we won't have time to cover them all. So yeah, it'd be worth going through the list and just looking at everything that's on there, so that you're familiar with all of these conditions. Okay, cool. Morning, Al. Good to see you. Read about Paget at the museum last week. Yeah, so we were at the Gordon Museum of Pathology last week at the anatomy labs, and yeah, the Gordon Museum is just crazy. There's like 3 floors and multiple rooms of 3 floors, all with pathology in jars. So if you want to see most of these things, they are probably in jars in the Gordon Museum at King's College. Cool. So this is where we are at. So yeah, some of the things that we were looking at this from last week. So we've got the vertebral body. We've got this here, the superior facet. Okay, so we talked about those last week. This is the vertebral foramen. That's where your spinal cord will go down. This area here is, well, this recess here is the laminar groove. But this whole area at the back here, this is the lamina. Okay. What else have we got? Spinous process at the back, transverse processes on the side. Okay, so we had a look at that in detail last week, so I'm not going to spend too much time on that today. And then, yeah, so we were looking at the facet joint orientation last week and the available movement in the lumbar spine. In fact, let's just have a quick look at that if I can. See if we can bring up that video. I think this might be it. Bear with me a sec. Let me just get queued up all the other ones. Let me get rid of those. Yeah, here we go. Okay, so this is what we saw last week. So it's worth just having a quick look at this again, just to recap. So here are your joints at the back. So that would be a superior facet. That's an inferior one. These are the spinous processes at the back. Transverse process here. There we go. So that is usually covered in synovial capsule, which is there. There you go. So that you've got a capsule over the joint. You can just about make out the joint line, and then when they move, you'll be able to see the stretch on the capsule as it moves. There it is there. Okay, so you're going to get a minimal amount of side bending, but just because of the structure of the joint. It will be able to flex and extend really well because they'll glide past each other quite well. And then, yeah, that's the neural foramina on the side there. Let me just go back there a sec. Just pause it at the right spot. There we go. Just pause that there. Yeah, so your nerves will come out of here. Okay, so when we get to the nervous system, we'll add those on in a sec. So that's the capsule around the facet joint, full of synovial fluid. So when you move, it encourages the production of synovial fluid. And because of the shape of the joint, it moves in flexion extension really well. It side bends somewhat, but rotation is quite limited, just because of how they fit next to each other. Okay, and that corresponds with this. Okay, so the shape of these joints will dictate the movement available at that joint. So the thoracic spine is shaped very differently, and you're able to get a lot more rotation out of the thoracic spine. Okay, cool. So if we have a look back at this then, see if we can make any more sense of this. So we've got no central spinal canal. So that's the main bit going down the middle. Okay, so they've called it a spinal canal. And this is the interesting thing with MRI reports. So this area here is spinal canal, but it's often called the vertebral foramen as well. Okay, sometimes called the spinal foramen. So there's, yeah, lots of different words for the same thing sometimes. So there's no central spinal canal or neural foraminal stenosis. So stenosis is like a narrowing of that area. So neural foraminal, the neural section, do you remember that bit of the video where I showed where the nerve comes out? So that's the neural foramina. Okay, so, or foramen, that bit there. Same with L1, L2. Minimal disc bulge, okay, but we know, I don't know how old this person was. I can't remember where I got this. I think I just Googled MRI report, and this is one that came up. Minimal disc bulge at L2, L3, okay, so depending on their age, it's going to be very likely that they would have one anyway, just because most people do, especially if you're in your 50s. Okay, so that's quite could be quite a normal finding. A mild facet arthropathy. So there are basically some changes to the facet joints, but they're very mild at the level of L2, L3. no central spinal canal narrowing, and no neural foraminal narrowing either. Okay, so that's the middle bit, and the sides are still open. Okay, we've got a trace retrolisthesis. Now we'll talk about that later, okay, because we're going to do, you might have heard of a spondylolisthesis, but a retrolisthesis, something slightly different. Minimal disc bulge, again, L3, L4 and L2, L3, so they could be just normal findings. A mild facet arthropathy, so again, the facet joints, there are some changes. No central spinal canal stenosis, so no narrowing down the middle. And there is a mild inferior, so underneath, foraminal narrowing, so the kind of beginnings of a stenosis bilaterally, so on both sides. Okay, so a mild inferior foraminal narrowing bilaterally. So where the nerves come out, there's a little bit of a narrowing on both sides. Okay, so that's the finding there. And then a 1.5 circumferential disc bulge, 1.5 mil, and again, could be a normal finding, but it could also relate to their symptoms. Usually you only get an MRI done if you're symptomatic. So that could be linked to their symptoms potentially. Okay. Again, mild facet arthropathy, so we've got mild changes to the facet joints, and then no central spinal canal stenosis. So hopefully just by kind of revisiting the anatomy a little bit, having a look at some of the names again, and then putting it into practice with MRI reports, you can see what they're getting at. Okay, you can see what they're trying to describe, hopefully. The trouble is, this information may be quite worrying for some patients, because like I say, they Google some of they's things, and then they're obviously going to find the worst images that you can find, and then have be nervous about their back. So it's good to be able to explain these kind of things and the prevalence of these things in asymptomatic people as well. Okay, cool. Right, let's move on. So we've got a couple of other bits of passive structures around the lumbar spine. This one's really cool. So this anchors the spinal cord to the coccyx. So your spinal cord finishes at around about the level of L1, L2. And then after that, all the way that fills the kind of lumbar spine region is all cauda equina, so horse's tail. It's lots and lots of spinal nerves basically coming off the end of the spinal cord. Okay, so what we've got on the end of the spinal cord is something called the ligamentum terminale, or the filum terminale, and this attaches down at your coccyx, so all the way down to the bottom of the spine, to anchor your spinal cord in place, okay, to make sure it doesn't ping up, basically. Okay. In general, yes, yeah. We tend to use arthropathy to describe. It basically means joint pathology. So there's some kind of joint changes. Okay, so yeah, that's a good question. Cool. This is really nice. This is from a book by a guy called Kapanji. Just write his name down here. So that's Kapanji. And he's written a series of books. There are 3 altogether, I think. There's one on the spinal cord and the pelvis, a spinal column in the pelvis. There's the hip and the lower limbs, I think, and then a shoulder one and upper limbs. So he's written a series of books. And the one thing I liked about Kapanji is how he kind of made the body into a bit of a cartoon, and broke down all of the areas, especially in the spine, because it's quite difficult to kind of get your head around which bit's which. So if we have a look here, we've got the vertebral body just here, and if we have a look at a completed version, so we've got this area all the way around here. So number 2 there, that's your lamina. Okay, but then you've got specific bits on the lamina, so 8 and 9 there, yeah, so that they will attach onto the back of the body, so then that becomes those bits, so that's 8 and 9. 8 and 9 will be your pedicles, okay, so those are the little feet coming off of the body. Then you've got your facet joints, okay, so superior and inferior facet in between the two, and then transverse process, and spinous process at the back, okay, so it kind of breaks up. Well, so yeah, number 5, 6 transverse process, number 7 spinous process. So it kind of breaks up all those regions of the vertebra, so that it makes it a little bit easier to picture which bit is which. Okay, so hopefully that's useful for you guys as well. Let's get that working. Here we go. Okay, cool. So let's have a look at these ligaments then. So we've got Ligamentum Flavum. Just get rid of Kapanji. Now, the orientation at which you look at these is really important to kind of get your head around where things are. Okay, so there's this is from the Trail Guide to the Body book by Andrew Beal, so B-I-E-L, and this is the view that we're looking at. So basically what they've done is they've cut across the back of the vertebral body, so through the pedicles. Hopefully these terms will make sense now. So through the pedicles here and here, and then see the arrow direction is looking towards the back of the lamina, okay, so, or where the lamina is, towards the back of the vertebra. So but you're actually looking, so if we have a look here, you're looking at the anterior part of the lamina just there, okay, and that's what this is. Yeah, so we're looking at that. We've chopped the body off. So if you imagine like this picture on the left here was in front of you, the vertebral body would be behind you. Yeah, so you're kind of inside the vertebral canal where the spinal cord will go, and you're looking towards the back where the spinous process is, but you're from the inside. So there's the lamina there. These are the facets. These are the transverse processes on the side. And there are some ligaments here and here that connect each lamina. Okay, so the one above to the one below. And it's called the Ligamentum Flavum. Okay, so there you go. There's the name of it just there. So we've got, yeah, you've got a pedicle that's been cut here, here, here. Yeah, so we're looking at the front part of the lamina from the inside of the vertebra. So Ligamentum Flavum is the yellow ligament. That's why it's given its name. So let's have a look at why. Just get rid of those. Hopefully this will be the Ligamentum Flavum. Here we go. Okay, just going to pause that there. Right then. So this is another image. So this is a side image of the all of the vertebra, and you've got the vertebral body just here. Then you'll have the pedicle, and then you've got the transverse, the spinous processes just here. There's the lamina on the inside, and then there's the Ligamentum Flavum. So this will be a side-on view. And this was the similar view to what we just had. So vertebral foramen just here. These are the pedicles. These are the transverse processes. Okay, so they're going to remove the vertebral bodies in a sec. So that's the view that we're looking at from the inside. So they're going to cut along that black line where the pedicles are. There we go. And then that's the view. Okay, so that's the view that was just on the picture. So we've got pedicle cut. We've got transverse process just here. There's the lamina. Okay, just there. So hopefully that makes a bit more sense. And then there is your Ligamentum Flavum. And hopefully you can see why it's the yellow ligament, because it is very yellow. So it's connecting every lamina to each other, okay, all the way up the spinal cord. the spinal column. And this ligament will often get mentioned on MRI reports. And the reason why it does is because if you think about where this ligament is, what it will do is it will help to prevent hyperflexion of the spine. So if you get forced forward really quickly, like in a car accident or something like that, some kind of, I don't know, sporting accident like skiing or something, and you get really quickly flexed forward, what that will do is it will stretch the ligamentum flavum. Yeah, so all of these, I say all of them, these ligaments will then be susceptible to be stretched. What will then happen is during the repair process, the ligamentum flavum will start to hypertrophy to rebuild the area that's been injured. And if you have an increase in ligamentous tissue around here, it will then encroach on the spinal canal, the vertebral canal, where the spinal cord is. So there's a risk that from the back with the ligamentum flavum that it can impede the space that the spinal cord has got. So if we have a look here, there's the ligamentum flavum just there, and then down there behind the vertebral body, that's where your spinal cord will run. So if this area here starts to get a bit bigger, it's going to push forward into that space. Okay, so that's why it's often looked at on an MRI. So there's your ligamentum flavum all the way down. And you can see it's quite a thick ligament there. Literally just fills that whole gap. There you go. So that's your ligamentum flavum. Right. So hopefully that makes make sense as well. Okay, with the view that you've just seen. This one's got quite a few ligaments on. So, but there are three main ones that we want to have a look at. So we'll do one at a time, and we'll kind of add them on as we go. So here's a vertebral body, intervertebral disc, vertebral body, disc, and so on. Okay, so that's obviously going to be continuous all the way up to your neck, but the shape will change as we go up. And then can you see this structure on the front? So that's called the anterior, because it's at the front, longitudinal, because it's really long, and ligament, okay, because of the type of tissue that it is. So it covers the front of the vertebra, front of the vertebral body, and it also covers the disc as it's making its way up and down. Okay, so that's the anterior longitudinal ligament, which looks like this. There we go. Just pause that there. Okay, cool. So you can see that it's just everywhere. Okay, absolutely everywhere. And when this is a really good dissection, but there's like strands of it, so it's not like a sheet that's just been stuck on like you see on the image that we saw in the books just there. But yeah, kind of strands of tissue that connect along every single vertebra, all the way from the sacrum all the way up to the top of the spine into the neck. Okay, so if you think about what this one might, the kind of movements this one might prevent, if you forward bend, this one is going to get shorter, so it won't have any impact on flexion. But what it will do is if you extend, that's going to tighten up the ligament. Okay, so it will reduce the hyperextension of the spine. Okay, let's have a look. So we've got vertebral discs, vertebral bodies, transverse processes just here. And this anterior longitudinal ligament just covers the whole front of your spine. And there we go. There it is in half. So if I just pop that there. So they've taken off half here to expose what's underneath, but you can also see the thickness of the ligament as well. So it's quite a thick, not as thick as the Ligamentum Flavum, but quite a thick ligament. But it's adhered to vertebral bodies and the disc. Okay, all the way up. And there you go. So if you go into hyperextension, then it will limit that movement, as will the joints at the back. So we've got a couple of things to help you stopping hyperextending. Okay, so that's the first one. If we go back to this image again, so we've had a look at this one. This is the anterior longitudinal. This one's probably the hardest one to get your head around and where it is. This one here. So this is the posterior longitudinal ligament. So we have one at the front. We've also got one at the back. And this travels all the way on the back of the vertebra. Okay. And it will also attach over and around the discs, but the middle of the discs, and then onto the vertebral bodies. And you'll see the shape of it is a little bit different, and it gives us a reason why we have certain herniations in the disc. So let's just have a look at that. Move that on there. There we go. Okay, so this is the posterior longitudinal ligament. Right then, so similar kind of view at the beginning, but last time the arrow view was different. So last time we were looking at the lamina, okay, so we're looking from the front to the back. This time what we're going to do is take off the back part of the vertebra so we can have a look at the posterior aspect of the vertebral body. Okay, so that's what we're going to have a look at this time. There you go. So back of the body there. So we're going to cut through these pedicles again. I'm going to take those off. There we go. And now we can see the back of the spine, so the vertebral bodies. And then there's your posterior longitudinal ligament. Okay. So can you see here that we've got a strand all the way down the center? So these are the pedicles. We've got a slight deviation either side where it attaches onto the discs, so they kind of come down a bit and then out of it, down a bit, out of it, like that. Okay, all the way down. Now we surmise that the reason why the posterior longitudinal ligament is there is to protect the spinal cord from a herniation of a disc, okay, or a disc bulge. So if a disc bulges, because of this really strong ligament down the back, it's unlikely to come centrally, which is that will then push on the spinal cord. What tends to happen is it goes posterior laterally, so it comes out here instead. But if we have a look there, we've got pedicle, and then but that is where your neural foramina is. So that's the opening for the nerves. So if the disc is pushed to the side, then it's going to compromise one side of the nerves, rather than coming centrally and affecting everything below. Yeah. So that's one of the reasons why we think we often get one-sided. Well, it is one of the things why we get one-sided disc herniations, and then also the symptoms associated with that. So there it is there, right down the center of the vertebral bodies, and then a bit of an attachment out to the sides. Yeah, so you've got vertebral body disc. So, and that area there, if I just go back there, so around this area here, that's where the neural foramina will be. Okay, so you can see there's no protection from the posterior longitudinal at that point. Okay, and then very briefly, last one, perfect timing, 2 in 1. So we've got this one, supraspinous ligament. So supra means superior, supraspinous ligament there, and then interspinous, in between the spinous processes. So 2 ligaments here, interspinous supraspinous, those two. Okay, so that's what they look like in the book. This is what they look like for real. Let me just open that up. Here we go. Okay, so there's your transverse process. There's your interspinous ligaments, so in between the spinous processes. So you've got spinous processes there and there. So this is a view from the side. There's your neural foramen. So that's where the nerves will come out eventually. And then there's the supraspinous ligament that goes on the top. So when you have a feel of someone's spine and you're feeling for those spinous processes, you're basically palpating the supraspinous ligament, okay? And you'll be able to push hard enough to feel the shape of the spinous process underneath. But that's what is on top of them, okay? So there are a lot of passive structures that protect the spine, okay, loads. So anterior longitudinal, posterior longitudinal, then you've got ligamentum flavum, interspinous, supraspinous. So all of those, all kind of in layers, all preventing different types of movement depending on their orientation to protect that spinal column and obviously your spinal cord in the middle. Cool. I thought I was going to have time to do the inguinal ligament, but no chance. So yeah, we will do that next week. We'll do a session on the inguinal ligament and look at herniations of the inguinal region as well. Okay, cool. See you next Monday.